So the next speaker, it's my very much a great pleasure to introduce Professor from Antwerp University, Stijn Verleden, who's really going to be talking about some of the research that he's been doing on the lung with a number of other members within the HOAHub. Stijn, I'll hand over to you.
Thank you very much, and thank you very much for the invitation. Happy to be here. I'll take it a little bit differently compared to anesthesia. I'll tell a little bit how I came across to this synchrotron radiation and this HIPCT technology, what I did before in short, and I'll try to show with some examples how useful it can be for applying it to your research. Right there. So just a basic anatomy 101 for people that do not know the lung very well, which probably there are some in the audience here. So the lung is a quite complex organ, and of course you have lots of airways in there, lots of airway generations in there. And what is important to realize is that all these structures are kind of difficult to see. Either with radiology, you can only see the bigger structures. With microscopy, you only see the smaller structures. And to give you an idea, what you see with a conventional CT, if you look at the number of airways, you can see right about there, like 10 or 11 generations of airway branching. And then you fail to see and you fail to resolve what is going on there. Actually, what is most interesting for most lung diseases is what's happening here below. There's, of course, some disease present there, but actually most disease is present here. So it's very difficult to investigate that in much more detail. And crucial in that aspect is that you can apply and know about the anatomical units, anatomical localization, where you are inside the lung. And this is about the best you can see with the regular CT scan. This is called secondary pulmonary lobule. Just to give you a very small, brief idea of the lung. As I mentioned, we have different modalities to investigate the lung, and I'm coming from a really medical field, so I'm also involved in patient diagnosis and things like that. And of course, radiology is crucially important in that. And for the lung, we mainly use CT scanning. However, CT scanning has some limitations. Of course, you have a 3D insight, so you can see the entire lung, you can investigate, you can scroll through it. It's non-invasive. You have radiation in the patient, of course, but it's, we try to reduce that as much as possible. And you can investigate the entire organ at once. However, the resolution is relatively poor. You see things, but you also miss a lot of things. As I mentioned, this whole branching of airways, you cannot see it on a regular CT scan. Pathology, on the other hand, of course, can give you the gold standard. It provides you high resolution information. You can see a lot of things in there. However, it's limited because you can only excise smaller tissue fragments. If you have to investigate an entire lung with a microscope, I think you will be busy cutting and investigating for a very, very long time. And of course, unless you do serial sectioning, you don't have 3D information. And you cannot do serial sectioning on everything. I mean, it just takes too long. So there's a big gap between those two structures. And during the initial phase of my career, I mainly used micro-CT as a bridge in between. So I used micro-CT technology because it also allows you to investigate an entire organ. We have a particularly nice micro-CT device in our university in Antwerp where we can scan entire human lungs with a resolution of about 150 microns. So this is already 5-6 times better than a conventional CT scan. And if you look at the different pictures, so this is here in vivo CT scan. We also take an ex vivo CT scan of the excised organ. So when we get the organ, we inflate it with air and we fix it in total. Then we do a CT scan and a micro CT scan of the organ. And you can see that the resolution is already slightly better looking at the same plane. If you then look at the micro CT scan, the resolution of the here is not fantastic, but it's a little bit like putting on your glasses and really seeing much, much better. What we then do is that we extract physically different cores out of this lung. So we slice up the lung, we take tissue cores out of this lung, which is illustrated by the red circle and the red cylinder here and the yellow cylinder here. So this is an area with extensive fibrosis. It's very white. So it's very dense material. And this is very interesting in the lung. The disease is very heterogeneous. So you can also see within the same lung, almost at the same level, you see areas which are minimally affected. And here at the top of the lung, there's even areas that are almost not affected. So this is what we leverage to learn more about disease, lung disease, but also about lung changes in healthy aging, in fibrosis, in different types of pulmonary diseases. What we then first applied it to was really as a sort of tool for correlative imaging. As Peter mentioned, we're interested in going from the macro scale to the micro scale. And these are some examples of studies that we did to look at early pulmonary fibrosis. So what we basically are interested in are these areas that are minimally affected on CT scan, and to know what their microscopical correlates are. So what is particularly interesting, of course, is that we see things on the CT that look healthy, but in fact are diseased on histology. So this is a little bit the goal, the holy grail, because this is the early stage of disease. Things you cannot see on the CT yet, but on the biological level, you already see the changes inside the tissue, which is illustrated here with fibrosis patterns. I will not go into detail because it's probably a little bit too far for this audience. But the basic principle is things you cannot see on CT, but are changed on the histological level. Next to a tool for correlative imaging, we also use it to quantify anatomical structures. So I'm mainly interested in the small airways, so the airways you cannot see on the regular CT. These are called the thermal bronchioles or transitional bronchioles. And based on these scans of these micro CT cores, this micro CT scan of the cores, you can quantify the amount of small airways inside the tissue. Because you can see the anatomical changes and you know the amount of tissue you're scanning it in. So you can quantify them per ml of tissue. And then we can see, for example, how the number of airways changes in health and disease. This is another example. These are patients here, these patients with precursor stage of disease that clinically do not show disease yet, but based on the micro-CT, we see extensive damage to the airways. The airways have decreased by almost half compared to the control lungs, just to give you some insight.
I did it for you.
And then you already see me gradually going to the hip CT field. We can also try and reconstruct and segment complete airway trees out of that with this resolution. And this is an example of a patient without lung disease, a patient with mild lung disease, and a patient with severe lung disease. And I was compared a little bit to a tree in summer, a tree in autumn, and a tree in the winter. So you see that the branches are falling off. You see that the airway tree is much less complex, and you see that the airway tree in general is degrading. In green, and this is also particularly interesting, is mucus filling of the airway. So this is the sputum mucus that's trapped inside the airway, and this is also something that is of particular interest at the moment in our society. So this is all interesting, and this is what I've been doing for a long time, but we still have many unresolved questions, because with this technology, we were not able to discriminate the vasculature, for example. Using the micro-CT, we have black and white, but the black and white was the same in blood vessels and in fibrosis or associated structures, anatomy inside the lung. So we were stuck there. I've been working on the airways for a long time, but an airway and an artery always run hand in hand, they run next to each other. So it's quite logical to think that when one is affected, the other one might also be affected. But we were not able to extract any information out of that. If you look at high resolution micro-CT, we physically have to extract the samples, scan them again to get the information. So we need to degrade or destroy the sample before we were able to further use it. And lastly, and also a very important thing, is that it remains challenging to reposition the micro-CT scans back to the entire lung. So we have to physically and mostly align ourselves manually, everything back together, which is a quite tedious job. So then, of course, COVID-19 came, and we were facing a disease which was affecting the lung quite strongly, which was affecting humanity quite strongly. Everyone was staying at home and we wanted to know more. This is then when Danny and Max and Peter started talking. And the first thing that we investigated was just looking at the vasculature inside the disease. And I think Danny and Max make tremendous efforts there in establishing the disease that was going on in the vasculature, because we saw these obliterations of the vasculature that were really destroying the lung specimens. And back then, the only thing we had was just a micro-CT scan of the tissue. So these are just some simple, very simple reconstructions of what was going on. In blue, you can see the airway. In red, you can see the vasculature, and you can see that the vasculature was narrowing and was not, the lumen was not completely filled with blood. So there was things obstructing the lumen. While in a normal case, this looked not how it should be. So we have a normal airway, a normal vessel right next to each other. And of course, this was very important to know more about. And this, I think, also the moment that Danny and Peter started talking, and Max, of course, started talking to each other and trying to develop this HIPCT technology. I stole this slide a little bit from Peter and Claire, but I just wanted to illustrate with the lung how it looks like and how we do it. So we collect now lungs from autopsies or lungs from lung transplant surgeries, lungs from lobectomy surgeries. We formally fix them, and this is how a lung with some kind of fibrotic pattern here in white on top of the lung looks like. Then the lung is mounted and the lung is scanned, reconstructed. We non-invasively can select these new regions of interest, and we can learn much more about the lung disease. And I will show now with a number of examples of things that are published, but also things we're working on at the moment, to show you how much potential this can have. So of course, going back to the COVID-19 and the work that most people here in the room were working on at that time was looking at the vasculature on a whole lung scale in these COVID-19 lungs. And it's particularly interesting and fascinating to see how it's deforming the microvasculature inside these COVID-19 lungs, which is nicely illustrated with these examples here, where you can see the different degradation of the vasculature inside COVID-19 lungs. And I particularly like this paper because this was the first one to be able to investigate the entire lung in much detail of a COVID-19 patient who died from the disease. And I talked previously about the secondary pulmonary lobules, this basic anatomical unit of the lung. And actually with the HIPCT, you can really discriminate them, and you can make this kind of checkboard pattern to see them and to see them in 3D, how they present, how they look like. And you can also look how diseased they are. And this is what you can see. So different colors present a different stage of disease inside the same lung. And to remind you, this will be something that is very, very challenging to see on a regular CT, because the unit, anatomical unit, is just too small to be reliably resolved on a regular CT scan. So this is why we need this kind of information. If I would look at this on a micro-CT level, I think everything would be dense. So everything would be dense white and would also fail to extract meaningful information out of that. And this here, for example, you can see these two different units there and there, with different examples here. So inside these secondary pulmonary lobules, you can then look even in more detail to look at the vasculature, to segment it, and to see how it manifests in health and disease within the same lung. And I think this is very important, that we can also use information from within the same lung, so we can compare the changes in normal appearing areas from a lung, and then also in the diseased areas of the same lung, so that you can look at the changes against the same genetic background. And I think the next step is then also to relate this to in vivo CT data, which is nicely done here, where we see also a patient with COVID-19 with pronounced changes here, the white ground glass opacification, consolidation that you can see here. And using the correlative imaging tools that at that time were developed here by Peter, by Paul, and by Max and Danny, you can really look in a lot of detail to the changes that are going on. You can see here in the airway, they were able to prove the existence of so-called sperarteries, which is anastomosis of the pulmonary arteries to the bronchial arteries. I will not go into too much detail about the exact function and anatomy of this, but it's just you can see things that we, with normal technology that are available, fail to see. We need this 3D information, and we need this contrast inside the vasculature to be able to extract that kind of information and to be able to quantify and investigate that in more detail. And then this is a nice movie, I think. Yes, it will be working. That was also made. So it really shows the potential and the degree of microvascular changes you can see. To remind you, if you have to do this by cutting and reconstructing this will be very, very challenging and very, very difficult. And I think this really gives tremendously nice images and really give an idea of what's going on inside the lung with a tremendous resolution, a tremendous amount of detail. Okay, so I will continue with some ongoing projects that we're doing now. So this is the work that has been done. Now I'm shifting gears a little bit to the work that we're doing at the moment. So this is work that is actually being done on the first HIPCT and HOAHub scanned organs. And the first example is the role of the fibroblast focus in lung fibrosis. The fibroblast focus is actually a key cell involved when a lung transforms from a non-fibrotic state to a fibrotic state. And it's considered one of the crucial cells in the disease pathophysiology. And this is an example here of fibroblast focus. A fibroblast focus is only identifiable on histology, and it's considered the holy grail of the diagnosis, although we have some arguments that it's not that holy anymore, but I will not go into detail there. But the fact is that you need histology to see it. You cannot see this on a regular CT. You need to cut up the pieces, and you need to be able to see it before you can make the diagnosis with certainty. And that's the idea that we have at the moment. So this is a pretty important anatomical and disease-associated cell type. And Joe Jacob, together with Ryoko, who did much of the work that I will be showing here, we were able to retrieve a sample of a patient with lung fibrosis, and we make it undergo hip CT scanning. And then we align it with what we see when we cut off the specimen. So we take zoom scans, we take an entire overview scan, and then we go into detail. And we were actually looking to find this fibroblast focus in there because the hip CT should be able to provide the resolution to discriminate this in more detail. And actually, this is a nice example. So this is the histology, which is still the holy grail. So here you can see a typical distortion of fibrotic lung, which is called a honeycomb cyst. That's what you can see here. You can see a lot of inflammation here as well. And this is the area that we're mostly interested in. So this thing here is a fibroblast focus. So this is something quite small to discriminate. But actually, when you look in more detail here to the hip CT scan, you can see the same structure being present here. And you can see that it differs from the microenvironment. So its density has decreased. The attenuation has decreased. And you can actually nicely discriminate this. And this was for us the golden proof, the proof of the pudding, that we can safely and reliably identify the structure. And when we can identify it, we can also quantify it in more detail. So we had to make up a definition as, for how we're going to define the fibroblast focus in lung fibrosis and how we were going to define based on the hip CT scanning. And together with Danny, we came up with a definition so that there's a slightly lower attenuation of the tissue, that the lesion is bulging into the alveolar space, and that there's no major vessel inside the lesion. And these are all things that you can see on the hip CT scan because you can see the vessels, you can see the attenuation difference. So we come up with the definition, and then we can quantify it in more detail. And depending on where the lesion is located, we can define it as mature or immature. When the lesion is inside the fibrotic area, it's called a mature fibrotic lesion. When it's not in a fibrotic area, it's called an immature lesion. So all of this to just explain you in more detail that we also took two regions of interest, zoom scans. This is in a heavy fibrotic remodeled area, and this is a normal appearing area within the same lung. And this is proven here. So this is the hip CT scans at exactly those areas. So in these areas and in two more areas, we started to quantify the structures. And we used hip CT to find that in total we found 406 fibroblast foci, which is quite a lot. We quantified 4 volumes. But in addition, I think this is most interesting, we can relate this back to what we see on the hip CT scan and on the in vivo CT scan of the same patient, so that we can divide these fibroblast foci in healthy areas and fibrotically remodeled areas. And these are the results that you can see here. So these areas were scored. So this is an area with limited fibrosis, only 5%. And to our surprise, we found a high degree of fibroblast foci being present there as well, because this fibroblast focus is considered a key area in the fibrotic remodeling. However, the fact that we also found it in areas with very minimal fibrosis is crucial in the fact that we think that it's not so typical anymore, and it might be some kind of general response to injury. When we then go to the areas, a similar area with a little bit more emphysema and a similar degree of fibrosis, we even see 103 fibroblast foci. When we then move to a higher degree of fibrosis, we can see that in the 60% fibrosis, there's 108 fibroblast foci. And in the area which is almost completely destroyed by fibrosis, we see 115 fibroblast foci. So in fact, there's not too much difference in the number of fibroblast foci per milliliter of lung tissue that we analyzed. And this is something we're investigating now in more detail, and that we're also trying to relate to biology of the fibroblastic focus, because now we want to investigate if the biology of the focus is different in these areas of heavy fibrosis and in these normal appearing areas. And this is a staining that has been done by our collaborator in Bern, Dr. Janine Beute-Schniering, where you can see proof of concept that we can do this multiplex staining on exactly those areas. And the next step now will be to quantify the nature of the fibroblastic focus in more detail. A second example is an airway-centered disease. I've been focusing on airways for a long time, so I cannot let this loose. So this is an example of a patient with that was transplanted. Yeah, it's fine. I'm almost there. An example of a patient that was transplanted, and typically you have fibrotic remodeling inside the airway there. We don't know much about that because it's only visible on the pathological scale. The question that we have is there a role for the vasculature, and how many lesions are present? And this is an example here. So this is an airway, this is a vessel, and you can see here that the airway is completely filled with fibrotic tissue, and then the airway reopens. So using HIP-CT, we're able to quantify the number of times we can see this phenomenon, so that we can extract that information and know how many lesions are present inside an entire lung. So we investigated our Zoom scans where we found 170 lesions. And if we extrapolate that to the entire lung, we can assume that in total, in one total lung, we have 568 airways that are obliterated with fibrotic tissue. Again, giving you the perspective of having a pathology, knowing a known amount of volume, and then associating it with disease. I'll skip this one. And then you can also nicely look at the vasculature that's associated with that. So this is here the fibrotic area that's remodeled, and this is then the artery, and this is the healthy areas that go around it. So you can really go in a lot of detail and investigate what's going on in the airways inside the vasculature. And then you can also see how that lesion is fed with arterial supply, as you can see here. So in green, you see the fibrotic remodeling, and in red, you can see the vasculature in more detail. Very, very briefly, last example that Teresa has been working on, which is called congenital pulmonary alveolar malformation. So this is a disease where typically the airway is not connected. Part of the airway tree is not connected. And we don't know what happens to the vascular supply in those areas. And we collected such a lung, we scanned it, and Teresa was able to generate very nice whole airway images. And you can nicely see that the airway really stops and fails to connect to the area of the cystic formation, while the artery runs through nicely. So all to give you an idea of what is possible. And this leads me to my conclusion that scanning of entire lungs is feasible. It's possible to analyze airway, parenchymal, and vascular structures because I showed you examples of all three cases. We can quantify this in more disease. We can quantify this in 3D. Important to realize that so far every organ needs another approach. Every organ needs another way of analyzing the HIP-CT scanning, and this will help us towards a better idea of modeling the lung in health and disease. So thank you for your attention, and thanks a lot for all these people that helped.